Good morning, everyone. First off, I want to say I've got a little cold, so just please, I don't normally sound this way. I don't normally have an accent, so it's the cold. So I've been here just a little shy of 8 months, so keep that in mind when we're going through the presentation, because Stony Brook is a great organization, but it's a large organization with many components. So keep that in mind when you're viewing my presentation, and keep in mind, 8 months, okay? I was counting weeks, but now I'm up to months. So I'm going to talk about what I've been able to discover. What are we doing and using now for data analytics? What are we developing or building, and what is our long-term strategy? For Stony Brook Medicine, we've been using analytics quite extensively. And one of the things I'm proud about being a part of Stony Brook is that when I go out and meet my peers, they're nowhere near where we are with using data analytics and being able to put that information at the end user's hands to be able to make real-time decisions. So we're using it to improve our quality as well as to help with our population health initiatives. We're really making strides in our quality improvement. We are putting the organization has made the commitment that we will be in the top decile for quality measures within 3 years. And fortunately, we're way ahead of that. We've got numerous measures that we're already in the top decile that we're actually getting awards on. And one of the primary reasons that we've been able to do that is because we've been using data and providing it in a useful manner at the clinicians' fingertips so that they know what they need to do when to take care of their patient to course correct. If you see, one of the foundational enablers that the organization is aware of is technology. They place huge significance on technology and data to be able to accomplish this task. One of the things that we're doing now is this is a dashboard of multiple facets of information that's pulled from all different areas to present in a dashboard to the clinician that is virtually real time. This allows the clinicians to be able to course correct for that patient encounter at the time versus being retrospective. But we're also using dashboards to be retrospective. We're looking at historical data to see what we're doing or how we did 30 days past. How many of our patients had to go back to the OR? How many of them are meeting the measures and really digging into this information post-discharge to find out what did we do, how can we do it better, and help creating standards that will help us to be able to create best practices in how we take care of our patients. We're also using it for business needs. We're looking across all the business units to try to see how well they're doing. And it's not to be punitive, but it's to see who's the best, who's doing best practice. Who's got the best outcomes? What are they doing? This also goes back to being a learning institution where if we see someone that's doing a great job, what are they doing? Can we replicate it? Is it something that we should be publishing to help the organization or help healthcare nationally to be able to improve upon? So we've got a lot of data at our hands. But the problem is, and Mary hinted to this, is how do you use the data? Massive amount of data is wonderful to have. It's a great commodity. But if you can't use it, it's not helpful in any way. So we're looking at tools to try to make use of that data that you can put in the hands of the people who need it to be able to use it real time. One of the things that we're focused on is population health. Our big initiatives are for using clinical registries. This is for mostly on our ambulatory side. Our clinical registries are near real-time clinical decision support for our physicians. They are, you know, when you go in to see a physician, I think every one of us has been in there, they're inundated with information. You don't get a whole lot of time with them. They're there, they can't review the complete chart to see, have you done your yearly test? Have you checked on your, have you done all the preventative medicine things? You're generally there to see what you're going for an episodic. But with the registries, it creates basically a dashboard for the physicians that is easy for them to look and see, you haven't had your blood work done, you haven't had your A1C checked yet, you haven't had, if you're diabetic, you haven't had your annual foot exam. You can see that, they can see that instantly. So it gives them tools and information to be able to take care of you, not just for the episodic care that you're there for, but for your whole well-being. We're just now starting on this. I mean, we're just scratching the surface. We have so much information that we can use to help our physicians and clinicians to better our health care, but we're just now starting. But we're ahead of the curve in the industry. As I was saying, when I go out to other CIO conventions or meetings with them, we talk about what we're doing for population health. I was just on a call this past week with the SUNY CIOs, and we were talking about what we're doing for population health. And we are years ahead of just about anyone in our area and across the nation. We're actually partnering with our vendor and pushing them to develop their product to help us to support our population health strategy. So we have about 153 users currently using the registries on a day-to-day basis. The data is approximately 6 hours old. And we have about a little over 200,000 patients that we have in these registries that we're using to monitor. What kind of registries are we using? Like I mentioned, we're using this for primary prevention. We have dashboards and information for pediatrics wellness, adult, senior, and maternity. We're also doing it for chronic disease management. We're looking at heart failure. How can we make sure that we do predictive in a way that we don't have a readmission because the patient is not taking their medications and their fluids are getting too high. We also have it for diabetes. We have coronary artery disease measures as well as hypertension. So we're using the data to constantly review these patients and see how well they're doing and what we need to do to course correct before they have to go into an acute care facility for an episodic. The other thing we're using with this data is we're using it to measure. I think everyone, you may or may not be aware, but there's a lot of regulations around healthcare. I know that's surprising, but one of the things we're using with data is, and the population health platform, is the ability for us to measure what we need for meaningful use incentive payments, as well as general meaningful use for the inpatient, and to create a patient-centered medical home. We're also, when I talk about having a large amount of data, we have a large amount of data. We have a data lake that has EHR data in it, not just Stony Brook's EHR, but community EHR. We have a connection to the Regional Health Information Exchange that has all the data in the state in it. We have claims, we have insurance claims in our data to be able to analyze, as well as reference labs. So we have about 2.7 million patients, about 16 million individual encounters, and at 72 million data elements. That's a lot of data. With that much information, with having the schools and the research, we can do a lot to better the world in general. You like my little cartoon there in case you can't read it? Everything's in the cloud, and the servers. I'm sorry I talk fast. We're also using the information for outreach capabilities like I talked about, but also for our grants and research. I mean, we are a data mega. We have so much information that we can use to help our research and education arm. And we're going to be utilizing that, and we currently are. We currently have 2 significant grants, hepatitis C, as well as aortic aneurysm screening programs because of this. I'm not sure if everyone is aware, but we're partnering with the state to do a reduction in Medicaid avoidable hospital use called DSRIP. It's Delivery System Reform Incentive Payment Program. That's a mouthful. I like DSRIP much better. We have been working on that for 3 going on 4 years, and we're using the same foundation for this type of population health management as we're doing in the hospital, which is our Healthy Intent platform that has that 72 million data elements. Now, prior to me being here, we had two separate siloed population health platforms. We had one that we were using for district, and we had one that we were using for Stony Brook Medicine. So what we're currently focusing on is how do we make this one for Stony Brook Medicine? There's really no reason to have two independent population health platforms. One is just really siloed for Medicaid, but they have the information that we need on the Stony Brook side, and the Stony Brook side needs district side needs the information that's in Stony Brook. So we're currently in the process of merging that into one, and that's not an easy task. It sounds easy, it's not very easy, because when you think about, we have, I think, over 40 different providers with different EMRs integrated into our Medicaid and our district platform. All that data has to be normalized. It's taken 3 years to get that, at least 40 of them in, data normalized and being able to create reports and use that data. So we have massive amount of data, but putting it in a usable fashion, it takes time. But now we're merging that in so that we can help the organization. But as you can see, we've got a lot of platforms to help with this. We have an integrated delivery network. We have a patient-centered medical home with care coordination and transitioning, which is huge to help decrease the hospitalization and use, because we're talking to them. Did you get your medicine? Do you need a ride to get to your physician? Do you need food? I mean, there's things that are not truly healthcare related, but has a significant impact on how well they are. So we're using the care navigators to try to figure out how can we keep them healthy. We also, as I said, have disease management, and we're using technology to engage with the members, with the patients, and giving them avenues where they can give us information and we can communicate back to them. That's significant, because what we're trying to do is change the culture of healthcare, and to not be like in my family's, my mother and father's, where they do everything the doctor says without questioning. We're trying to help the society take ownership of their health and ask questions and be a participant in taking in their health care, and not just be a passive receiver of it. What are we developing? This is the exciting part. Mary alluded to it when she said that we all have to lean on each other, we all have to work together. So in the 8 months, I've been working very closely with Dr. Jerry Kelly and with Dr. Joel Saltz, and we're developing a lot of good things that's going to help the organization move ahead as a whole. We're utilizing all the different facets to build partnerships to help us grow together versus siloed. Some of the things we're doing, we're developing a BMI, a Biomedical Informatics Fellowship Program. We're looking at the schools. We're going to be partnering with the schools to get the graduate students to work on real life problems to help us. Not only will it help us, but it will help reinforce their education. We're also, and this was prior to me, I can take no credit for this, but it's a wonderful thing. It's called a hackathon. I had no idea what a hackathon was, but it sounded cool. I pictured somebody in there trying to see how hard they hit the keyboard, which is what I type. But no, they're doing some amazing things. This is open to the community, to the schools, to the staff here. It's an open door type of environment that allows us to help with developing, training students, identifying the latest technologies, reviewing the latest technologies, looking at the software and what's our projects, or showcasing our projects, coordinating resolution of technical problems. There's massive amount of technical problems. One of the challenges of a CIO is everybody thinks you can buy a tool that will fix every problem you have. So you buy 10 tools. None of them work together. Each one will fix one problem, but collectively they fix no problems. So that's one of the reasons that we have the hackathons. How do we take and make this technology work together? And we're also looking at the newest technologies and doing massive amount of discussion to find out if there's not a technology out there, maybe we should build one. which leads me to our innovation group. We're developing an innovation group, which I believe David's going to be talking a little bit about later. That includes a governance process and is with David and Dr. Kelly as well as Dr. Saltz on what problems do we have in our organization? How can we fix them? What tools do we have? Do we have the right tools? Do we need to develop the right tools? And really put this into real life. This is things that we will implement and make the organization better. So what are we hoping to do with this? What are we hoping at the end of the day when we get all these things solidified? We want to be an organization that uses the full spectrum of analytics. We want to be efficient with using our information. We want to be agile. That is something that is very difficult to be when you have you're so large and so much information, but you have to be. We want to be innovators. And we also want to automate that. This is our goal, is to make sure that we can do this in a systematic, process-driven, governed, regulated project that, well, I shouldn't even say project. It's a foundation for our schools, for our research, and for our clinicians. And what do we hope at the end of the day that we will be? We'll be an innovation center of excellence. That we will know how to take this mass amount of data and what to do with it. It won't be that we're sitting here saying, you've got that data, can you help me to identify the patients that will, in 10 years have cardiac failure? We'll be able to have the brilliant minds and the researchers and the BMI to figure out the algorithms to run across this data to help us to do predictive analysis.